All right, I am quickly going to just run through some introductory slides, just talking about the topic itself. I don't have any conflict of interest related to this topic. I want people to just become aware once again of the prevalence of major depression in people with substance use disorders, learn about the different types of brain stimulation, and then just a little bit about the impact of frequency on brain and behavioral activity. So, as everybody in this room probably already knows, depression is one of the most common comorbidities across substance use disorders, mainly because it's so frequent in the general population. Even though the odds ratio, you took a PTSD, bipolar disorder, much higher odds ratio, but just in terms of the numbers of people, because depression is so frequent, that have this, this comorbidity is common. And if you look at all the epidemiologic survey studies done in the last 25 years, it's about twice as common in people with substance use compared to the general population. And if we look at opioids in particular, current major depression up to 30%, lifetime up to 60%. And because the prescription opioids are of such concern these days, what's so interesting is this is really a two-way street. Individuals who have depression are much more likely to initiate prescription opioid therapy. And then they are 2 to 4 times more likely to transition to chronic use compared to someone without depression. And then, on the other hand, people, even if they did not have depression when they start opioid therapy, they are 9 to 12% of those after initiation, they develop a major depressive episode, and the chances of that increase both with dose and with duration of use. So a very common risky comorbidity. Very old slide, but I just think it gives us a principle that we need to keep in mind here. I don't think I've got a pointer here. So, okay, 2 important lines right here. This is, of course, a survival analysis, and we're looking at people with depression, not depression, coming out of treatment for substance use disorder, alcohol use in particular. This top line here are people who are depressed and received an antidepressant. So their survival is pretty good compared to these others. This bottom line here are people who were depressed by diagnostic interview and did not receive treatment for it. So treating people with both disorders is extremely important. Treating their depression is extremely important in terms of their substance use outcomes. Another one of my favorite meta-analyses by 2 of our icons are AAAP icons, Ned Nudis and Fran Levin. They really looked at every decent study up to about 2004 of co-occurring, double-blind, placebo-controlled treatment of co-occurring substance use and depression. And let me just go in the wrong way here. And what they found, now remember, one of the big things here, these studies right here are all studies that had a placebo response rate of more than 25%. Now, what explains that? That's probably sort of sloppy diagnostic technique at the beginning of the protocol. You take people in early, their depression resolves anyway because of substance use. It was gonna resolve anyhow. So your placebo response rate is elevated right here. But with careful diagnostic techniques and the placebo response rate will really decrease. And if you look at that, if the placebo response rate is less than 25%, all of these studies favored medication. So careful diagnosis is important, but with careful diagnosis, even if somebody has both substance use and major depression, the depression will resolve if you treat it. And then, well, what happens if you treat it? Do the substance use outcomes get better? So does treating depression help substance use? And what you can see right here is that all of these studies, again, effect size greater than 5. These are the same ones that did a good job with diagnostics. So you can see in well-done studies where the diagnostics are carefully done, depression treatment improves depression, and improving depression pretty much goes along with better outcomes for your substance use. So this is another really nice study, Helen Petnati, looking at, again, depression and alcohol, double-blind, placebo-controlled, naltrexone, sertraline, together and independent with a double placebo And what they found that was so remarkable is that there was really a synergistic effect. So what blew me away about this trial in particular is we're talking about drinking, but the depression numbers look about the same. When people are on this combination, there's actually a synergistic effect, whereas the naltrexone didn't really seem to decrease the drinking that much in these individuals. Naltrexone alone, even though it's approved for drinking, in this comorbid population, doesn't do any better than sertraline alone or placebo, but the combination is actually a synergistic effect, and the effects on depression look very similar. So again, just evidence, treat aggressively, and use whatever tools you have in your toolbox is what I'd say that can be safely used.